points. I also noticed that we used to split up into a gynecology room and a non-gynecology room, so when I realized that we weren't splitting up, I took out some of the more technical insertion, correction of complication things that I didn't think would be as much interest to the whole audience. And if Lee and the rest of the people who are running this don't kill me, I will give you my presentation that they can send to you, which encompasses all of that, so you'll have it as a reference, and you can see how good I am at this, so we'll see how that transpires.
Good.
Anyway, I have no disclosures. Objectives, we're going to review the 2016 U.S. medical eligibility criteria for contraceptive use, but more important than that, because that would be a whole hour in itself, we're going to apply it to everyday practice. I'm going to talk about, again, a little bit less on this, but I am going to talk about some of the emergent issues and some of the problems with the long-acting reversible contraceptives. And then talk a little bit about some of the new stuff that's coming out, which is really exciting to us, about risk reduction for ovarian cancer and self-injectome, which is finally exciting to have something we can do to help women with ovarian cancer prevention. The contraceptives, I don't have to name them, we all know what they are. We have the IUDs, progestin only, the combined pills, the barrier methods, the fertility awareness-based methods, lactational amenorrhea, and coitus interruptus. I'm not going to focus too much on people who use the fertility awareness-based method, which is checking mucus and basal body temperatures. They are so good at it, they're probably better at it than I would even be in explaining it. Lactational amenorrhea, what I tell my patients is the ballpark is if you're breastfeeding at least 5 times in a 24-hour period. That doesn't mean 5 times and then you sleep for 12 hours. It has to be 5 times over 24 hours. That generally speaking, the vast majority of people are protected for 5 months. However, if you don't want a little surprise in there, you should probably not take that one to the bank. Coitus interruptus, believe it or not, has about the same efficacy as the average use of diaphragms. So unless you're using your diaphragm correctly, coitus interruptus is probably just as good. I also don't tell people that. Emergency contraception, I'm also not going to talk too much about. New solutions, the long-acting reversible contraceptive, or LARC. These are the intrauterine devices, and the implant, which the only one approved right now is NEXPLANON. They're not even that new anymore. I think they've been around for a while, and most of them are getting more comfortable with them. The one that is new is Kyleena. Kyleena is basically the same size as Skyla. So remember, Skyla is the smaller one. So Skyla is the one that's approved, FDA approved for nulliparous women, even though we were putting arenas in for nulliparous women for a while. Skyla is good for 3 years. Kyleena, I would love to be in one of these meetings where they name these things. Kyleena is the same size as Skyla, but is good for 5 years. So that's a great new option, FDA approved for nulliparous women. The copper IUD is Paragard. We all know that that is good for 10 years. Again, also approved for nulliparous women. And I talked about already NEXPLANON, which is a 3-year rod that goes into the arm. I just want to mention Kaya. Kaya is the new diaphragm. I know that some of the younger people in here have not really used or recommended diaphragms. We all use the old Ortho Allflex. Ortho Allflex is virtually impossible to find anymore, but there certainly is a population of women who like to use a diaphragm, and Kaya is the new Ortho Allflex. It's got a great design, it's easier to put in, it's easier to take out. It has the same effectiveness as the male condom. You have to use the contraceptive gel within 2 hours of sex and leave the Kaya in for at least 6 hours afterwards. You have to reapply contraceptive gel if you use it, if you have sex more than once within that 6-hour period. Basically the same instructions as the diaphragm. My favorite part of Kaya is One size fits most is kind of their advertisement. So what I recommend is if you are fitting them, you can go online to the Kaya website and ask them to send you devices to the office, and they will send you single-use disposable devices. They have a hole in them, so you can't actually use them for birth control. But you can at least fit them in the woman and make sure that they are not the exception to the one size fits most before you give a prescription for it. So now we're going to go on and talk about the U.S. medical eligibility criteria. The original version was 2010. It was last updated in 2016. Basically, it's a guideline for what contraceptives you can use in patients with different medical problems. It has a companion document called the Selected Practice Recommendations, the SPR, which basically tells you how to use the different methods. It breaks it down into 4 categories. Category 1, we love, no restrictions. Category 2 is generally good, but you have to have close follow-up. Category 3 is it's generally not recommended unless there are no other more acceptable methods to use. Category 4 is don't use. So if it's category 1 or category 4, it's pretty easy. Category 2 and 3, we still need to think about a little bit. Again, back to apps. I don't know if people are going to talk about that in the app talk, but there is a U.S. medical eligibility app. And does anybody know of this app or use this app? I'm so glad that that answer is no, because if the answer was yes, I would just have to leave right now. So we do have an app for that. And this is what the app looks like. And it's free, and you should download it, and it's awesome. You can search by condition. You can search by contraceptive method. And then it also has the SPR in there, so it tells you how to initiate the method, monitor the method, etc. Again, I should really look at the syllabus before I write these lectures, because I chose hypertension as my example, but I'm going to run through how it looks on the app, and we're going to do this with a couple of the cases. So you have a patient who you have on combined oral contraceptives. Say she's 36 years old, she's a non-smoker, she's otherwise healthy. She comes back to you to renew her pills, and her blood pressure in your office is 142/90. From now on, what I'm going to do is put them in a room, put the lights out, and go back. Since I haven't been doing that until now, I would just repeat it or bring her back maybe in a month and repeat it again. But if I still have that elevated blood pressure, what do? So I would go to my app. So if you take the app and you go to condition, and it'll bring up all the conditions, and it's a nice alphabetical listing, although some of them aren't inherently alphabetical, so you have to kind of look through it. And then you would hit history of high blood pressure or hypertension. So you hit hypertension, and then it'll actually break it down to adequately controlled hypertension, elevated blood pressures. They'll even break it down to your systolic, diastolics, different numbers. So you have 142/90, so you would hit under B, the first one, and it's going to come out with those numbers, 1, 2, 3, and 4. Remembering 1 is all good, 4 is all bad, 2 and 3 you have to think about. So not only does it have all those numbers, but it has 2 other parts that are very helpful. 1, the initiate. That's a number for should you initiate that birth control method. And 2, continue. Should you continue that birth control method? So in this particular example, it's the same whether you're starting it or continuing it. And if you go down to combined birth control pills, which was what she's on, it has the 3. But even more than that, if you then click on that, it's going to give you the evidence about why she should or should not use this method. So it's an absolutely fantastic app. I actually take my phone into the office visit with me when I have patients with these conditions, and we run through the apps and say, okay, you don't want to stop your pill, because the argument's always, I've been on it forever, I was rushing today, my blood pressure's high because of this. And you can say, okay, well, you're at a higher risk for stroke, heart attack, things like that, and you can really go over things. So this is where if I had a mic, I could do my mic drop and walk out, because that's all you need to do contraception, right? Well, the problem is category 2 and category 3, where we still have to think a little bit. So, this is where I'm going to start some examples. We have a 34-year-old who comes to us. She's had bariatric surgery. Her current BMI is 33, so she still has a little ways to go. She had a history of diabetes and hypertension, but they have resolved since she had a 125-pound weight loss. She has a 14-week size uterus and heavy periods. She uses condoms, but her partner doesn't like them, and she doesn't want a barrier. She would like another pregnancy. Okay, so unfortunately, these are kind of our patients. Nobody just comes in and they're like young and thin and healthy and happy and want a pill. Her blood pressure is 128/76. So these are all her problems. Her weight, diabetes and hypertension, we can argue they're probably not a problem anymore as long as you ask her, has she had any, has she had a normal creatinine, is her EKG okay, things like that. She's had the bariatric surgery, and she has a fibroid uterus. So let's go over our choices. Intrauterine contraceptives, well, she also has heavy periods, and we know that the copper IUD is going to make your periods heavier, probably heavier and a little bit more painful. So that's an issue for somebody who has a fibroid uterus and already has heavy periods. Having a 14-week size uterus is a little bit above the limitation for Mirena IUD, but sometimes you can try it. Sometimes the cavity's not as big. It's always worth a try. She can use progestin-only contraceptives, pills, which you know are not as effective, right? They're 92% versus 97 to 8% for combined pills. Implants, which is the rod, or shots. Again, I talked about Depo-Provera before. I'm certainly not going to give it to somebody who's in the middle of a weight loss program. Combined pills, patches or rings, or the barrier method. So if we work through, we're not going to do kind of those. So this is what we're left with. Okay? So if we still, again, we still have to think a little bit. But then if we have these left and we're trying to say, well, what really is the best one for her, you can go to your app. Since she has multiple conditions, you can kind of make a little flow chart in your head or say which one is the one I'm most worried about. And you can look. So you've got lots of 1s and 2s. The only 3 you have is the combined pill because of hypertension. But again, not so worried about that in her. And then what's interesting is when you look up bariatric surgery, it actually talks about restrictive versus malabsorptive surgeries, which quite frankly is something I don't know that I would have thought about without having had this app. So I think I did, let me remember. Oh, I'm hitting the pointer instead of the button. Okay, so if we go back to our app and we go by condition, you can actually look up history of bariatric surgery. It will give you the restrictive versus the malabsorptive. Since she didn't know which one she had, if you look up the restrictive, there's no contraindication to any of them. You can use any of them. But if you're not sure, you can go back and look up malabsorptive, and then you can see that anything that is based on absorption, the progesterone-only pill or combined oral contraceptives, that they're going to have a little bit more restriction because of the potential of malabsorption, because of nausea, vomiting, diarrhea, or malabsorption. Okay, what's interesting is the patch and the ring are okay. Why? Because they're bypassing the GI tract. So then you can go back, you can look again, that tells you why. So you can go back to your patient, look at all of those, and say, well, we can try the Mirena, the ring or the patch, or the NEXPLANON. Again, in somebody who's really working on weight, I think that my first choice would be the Mirena, just because I like the Mirena. I think there's a little bit of an issue with her increased uterus. And this is what's really sad to me is that I could not find, this was an actual patient of mine, and I put a Mirena in, and she came back about 6 months later, and all of a sudden she had heavy bleeding again. And we did an ultrasound, and it was, I can't remember her name, so I couldn't find the ultrasound, but the Mirena was upside down. It's the first time I ever saw that, and even when I searched online, I couldn't find a picture. So we had to go in there, and we grabbed the Mirena and got the Mirena out, and then I think we put her on a ring. But anyway, so you try, you still kind of run into problems. So here's a 27-year-old, heavy periods, anticoagulated because she's had a PE while on combined oral contraceptives. She was found to have factor V laden. She has one child, wants another child. She has some intramural fibroids, each about 5 centimeters, and her BMI is 32. So again, you have to pull up your issues: heavy periods, pulmonary embolus, anticoagulated, fibroids, obesity. Again, I know these are simple cases. It's really about training your mind to pull out the important things and address the important things in your mind. So let's go through what our choices are. Obviously, we are not going to do a copper IUD, right? We're not going to do a copper IUD because it's going to make periods heavier. She can't have anything that has estrogen in it, so that's going to leave us the levonorgestrel-containing IUDs, the progestin-onlys, and barrier methods. So that's where it's going to leave. I don't know if I did. I don't think I pulled up the app for this. I just put together the chart. So when looking at this chart, you can see the safest, absolute safest thing for her is barrier. Now the problem is, this is a patient who you really don't want an unexpected pregnancy in, isn't it? This is somebody who kind of has to be prepped for pregnancy, the anticoagulation, things like that. So you want to look at some of the other more reliable methods than barriers. So you can look, and they're kind of all things created equal. So if all things are created equal, you have to do a little bit of thinking, right? So you have to look at problems one at a time. What's her most significant problem? What's going to kill her? Her fibroids aren't going to kill her. Her PE is going to kill her. So think about further discussion. Depo-Provera, again, she's a little bit overweight, and I don't like Depo-Provera and overweight. And also, Depo-Provera seems like an awful lot of drug for somebody who has a coagulopathy. I would worry a little bit about NEXPLANON in an anticoagulated anticoagulated patient. What is the biggest problem with NEXPLANON? Bleeding. The biggest side effect with NEXPLANON is bleeding. How do you correct the bleeding with NEXPLANON most effectively? Is with estrogens. So you're not going to be able to correct heavy bleeding that she's having with an NEXPLANON. And it's not like an IUD where you can pull on a string and it's out. It's another surgical procedure to take it out. How many of you put NEXPLANONs in? Okay, do you go back and look at that huge bruise that people get even when they have normal clotting factors? If people come back to you within 24 or 48 hours of a NEXPLANON, it's pretty frightening looking. They really bruise. So remember to tell people that. It's going to look ugly, but that's pretty normal. So I would try, if she's going to use a barrier, maybe the progestin-only pill. Again, it's not as good as a combined pill, but it's not going to be a risk for her. And if you combine it with a condom, you're going to get good efficacy. I would consider Mirena, which would also, I think, be a good choice, although the first few months might be kind of rough, right, until you kind of settle in to the Mirena. And I have to put that in there because her hematologist would disagree with all of this. We still have, even though the clotting risk with the progesterone-only methods is very small, the FDA will never take it off the label, and our hematologists argue very strongly about us using any kind of progesterone, so you have to have some communication with your hematologist. Okay, you've done a D&C for a missed abortion on a 37-year-old who does not want any more children. At the time of the D&C, you inserted a Mirena. Okay, perfectly reasonable thing to do. Her pathology comes back with a complete molar pregnancy. You've been following her betas, and they've been dropping adequately. Okay? This is a problem that I wouldn't even know where to start looking up what to do with this. Right? But you guys, I will be doing literature searches and everything. She's got a complete mole, she's got a Mirena. So what are we going to do? Go right to the app. It actually has, if you go to select by condition, it actually has gestational trophoblastic disease, which I think is awesome. And if you go, it will break it down to suspected or confirmed. Hers is confirmed. It says undetectable betas, decreasing betas, persistent. It goes through every scenario there is. And if you look at decreasing betas, Okay, it may not have been what I would have chosen to give her if I was doing birth control, because initiation is a 2 and there's better choices, but certainly it's perfectly okay for me to continue it. So I think it's very reassuring to know that in the complex cases that we don't run into every day, you really do have a good resource to go to that actually doesn't just tell you what to do, but actually tells you why to do it. It tells you, again, benefits of contraceptive, weighed against the potential need for removal, and why is it telling us that it's okay to use it. So I think we have to take the patient, think about what's the most important problem, start at the most important problem that we don't want to make worse, and then factor in all the other conditions, including their preferences. And that's how you choose the appropriate contraception. 17-year-old comes to you requesting an IUD. This is one of the problems that's coming up a lot, I think, with the long-acting reversibles. Her friends all love their IUDs, and she's bad at remembering to take pills. She currently uses condoms. She's going to continue to do so because you've done your safe sex talk with her. Her periods are irregular about every 3 months. Is that thunder? Wow. She has no medical problems, but she does have severe acne. Okay, so if you look at her, she wants an IUD. She doesn't want to take pills. She has irregular periods and acne. Okay? So she may have PCOS. You can do the whole PCOS workup and make sure there's nothing else underlying, but the bottom line is we're still going to treat her irregular periods. She wants an IUD. She's bad at remembering pills. I put that in there because that's not a medical problem, but certainly a consideration. What's the problem with the IUDs and acne? Why do dermatologists send all their acne patients to us? To put them on pills. So they can have the benefit of the estrogens, which are going to raise the sex hormone binding globulin, lower testosterone to help their acne. So if we're doing any of the IUDs, we're not really helping their acne, plus we're not helping their irregular periods, which again, rule number 1, protect the endometrium. We're not doing that either. So we don't want to use a copper IUD because that's not going to protect her endometrium. She doesn't want to take pills. Again, with acne, I would stay away from the Depo-Provera. She doesn't want to take pills, and she's already going to be using a barrier method. So we come down to irregular periods, the levonorgestrel, NEXPLANON, or a patch or a ring. We can avoid you taking a pill by using a patch or a ring. So we go to the guide, and oh my God, it's not in the guide. So now we have to run out of the room, pull up books. I mean, we just have to think a little bit. This is a pretty basic one, but it's something to remember because I'm putting in an incredible number of IUDs. They're fantastic. They're great birth control. There's study after study showing how they're decreasing the teen pregnancy rates everywhere, but we have to remember to treat the whole person. And if we just put an IUD in her, I put my own numbers in. I said, okay, I don't have it in the guide, so I'm going to put my own numbers in. If I just put an IUD in her, I'm not really going to help her. I can give her anything, but the levonorgestrel, there's no downside to any of it. NEXPLANON, again, in irregular menses, she's coming to me because she wants to fix her irregular periods, so my giving her more irregular periods is not really going to be the way to do it. So, what are your options? It's just like I talked about in perimenopause. Things are a mix and match. It's like a Chinese food menu, one from column A, one from column B. Put them together to make a happy patient. So levonorgestrel IUD plus an acne treatment. Any of the family practice or internists in the room or anybody who treats acne will scream at me when I say spironolactone. Sometimes I add that in a little bit. When you look at the acne treatment guidelines, I know it doesn't come up. They have all the topicals and the antibiotics and everything else. You always go to what you're comfortable with. We've been giving spironolactone for hair for forever in acne, so I sometimes add that in. NEXPLANON plus acne treatment, again, the spironolactone, or hopefully a dermatologist involved, plus good counseling. That she's going to go from periods every 3 months so potentially more bleeding until it finally settles out, or the contraceptive patches or rings, where she doesn't have to remember to take a pill, and they might be more acceptable to her, and it'd be more one-stop shopping. Keep going. 37-year-old requests a tubal at the time of her third section. The pregnancy has been complicated by high blood pressure and diabetes. At the time of the surgery, she has adhesions. Basically, you can't do the tubal because you can only get to one tube. So you've delivered the baby, but you can only expose that one tube. She's awake, she's had an epidural, you can talk to her, you can go over different things. So what are her issues? Right there while she's laying on the operating room table, you can talk to her a little bit. If we want to go through this, I'm just going to skip ahead. We don't want to give her with her diabetes and hypertension. We don't want to add birth control pills. Again, the progestin-only things, you can tell I don't like them. I don't particularly like them, although definitely you can talk to her about an implant if she's interested in that. Barrier method, this is her third repeat section with lots of adhesions. That's not a belly I want to go into again, so I want something a little bit more reliable. So we're down to our IUDs or sterilization, which is what she wanted in the first place. So hopefully her husband, who's sitting behind the curtain, will jump up and say, "Don't worry, honey, I'll go have a vasectomy." That's never happened in all the years I've practiced, so I probably wouldn't count on that one. So what can we do? We can do an immediate IUD postpartum if you have that ability in the hospital. So we've been fighting very hard for that ability in the hospital. The problem is, unless we plan it really well and order the IUDs beforehand and make sure insurance is going to pay them, make sure they're available when the patient comes in, make sure we remember to put it in, and then make sure we bill it correctly, it doesn't happen. So it doesn't happen often. We are working really hard to start making that happen. You can talk to her about doing an Essure postpartum, because certainly she's not somebody who you're going to try to do laparoscopically in the future. Or, again, the husband's vasectomy. So let's talk a little bit about what's going on with Essure, okay? It's a good birth control method. It's 99.5% effective. The downside that everybody talks about is that you can't just put it in and say, boom, you're good to go. You have to have that 3-month post-placement confirmation to make sure that there really is tubal occlusion. How does Essure work? The tubes scar down around it. You have to make sure there's complete scarring around the Essure. So that has traditionally been done with a hysterosalpingogram, which is a little bit of a burden because they have to go to a radiology group. It's under fluoroscopy. It's a little bit more difficult than what we usually do with our patients, which are ultrasounds. There's some new data coming out showing that it may be effective, just as effective to check it with sonohistograms and also just plain sonograms they're working on. So some of that is kind of coming up in the literature. I don't think we recommend it yet, but I know there are some studies going on, so that may eliminate one of the barriers. At least it's something most of us can do in our office, as opposed to counting on handing a prescription, having them go out, making sure they follow up on it. The risks, most of the pregnancies, most of the failures are in the women who don't come back for follow-up. So it's usually not an operative failure, it's usually not a placement failure, it's usually that it hasn't completely scarred down, and so there is potential for pregnancy, but the women haven't come for follow-up, so that you don't know that. The risks are the risks that we always knew about, tubal or uterine perforation, and then the allergy or hypersensitivity reactions to nickel. I think what all the controversy has been around have been the chronic pain syndromes that have developed after Essure or Essure, I pronounce it both ways depending on the minute and the day, and also some people who are complaining of autoimmune-like symptoms. The incidence of this varies very much with what studies you read. I started to read studies to present some stuff on it. They're all over the place. I think the biggest problem that's gotten the most press is the chronic pain. The problem is once it's in, and you can't just pull it out. So once it's in, if there's a chronic pain problem, You have to either remove the entire tube or even do a hysterectomy. Most people just go in and take out the tubes. Again, in this patient with all the adhesions, that might not be the best idea because if it did fail, you don't want to be in that belly. So what happened in response to these reports about the pain is the FDA put a black box warning on it. Once the FDA puts a black box warning on something, it's kind of the kiss of death. And it just reiterates what we talked about, which are the known complications from insertion, but also the chronic pain issues. But the FDA still feels the benefits outweigh the risk in carefully selected patients. This is not the kind of thing you put into an endometriosis patient. You don't put it into a chronic pain patient. You want to put it into a reliable patient who's going to follow up, who isn't starting out with chronic pain. You don't want to put it in a fibromyalgia patient. You want to choose your patients. What does ACOG say? Again, I tried to find a definitive statement from ACOG. ACOG is really good at not giving definitive statements, which is probably to our benefit because if they did, they could always be held against us. ACOG just basically listed as an option, talks about the risks and benefits, and reiterates carefully selected patients. Okay, this is an interesting one, and I'm hoping the endocrinologists in the room will be proud of me for this. A 23-year-old comes to you requesting contraception. She's had no periods for 14 months. Okay, you do a workup on her. She has a normal prolactin, normal thyroid, normal FSH. This is one of the areas where you want to do an FSH, right? Because you want to rule out premature ovarian failure. Of course, you could have done a Provera challenge, and if she didn't bleed, then do the FSH. And we do an MRI of her head because she's got unexplained amenorrhea. It's negative. Well, we do a really good history, and it turns out that she's a gymnast who's practicing 6 hours a day, and her BMI is 17. I'm seeing more of these patients now that Rutgers, we have merged the history of our school. This is interesting. Since we have all this time, I can tell stories. I went to Rutgers Medical School back when it was originally Rutgers. While I was there, that's the whole thing. While I was there, Rutgers Medical School became UMDNJ Robert Wood Johnson Medical School. So when we graduated, we were like, okay, we can either have a diploma from a school that doesn't exist or a school that nobody's heard of. So they graciously gave us a diploma with the name of each school on it. So it's been UMDNJ Robert Wood Johnson Medical School for the past 20 years, and within the past 2 years, we've become Rutgers again. So now we're Rutgers Robert Wood Johnson Medical School, because we always have to have the longest name in the world. So I can take down one diploma and put my other diploma up. What's the point of that story? The point of that story is now that we are officially Rutgers Medical School, we treat all the athletes. So we're the referral center for all the female athletes in our gynecology department. So I've been running into patients with hypothalamic amenorrhea more often. Now, how do we always treat patients with hypothalamic amenorrhea? Let's talk about it a little bit. Basically, you can give her anything, right? She's young, she's healthy, we can give her anything. Hypothalamic amenorrhea, what we need to be concerned about is what used to be called the female athlete triad, which ironically stands, the letters are fat, which menstrual irregularities or amenorrhea, which can lead to, but the menstrual, they're from low estrogen levels, so you can have bone loss and actual development of osteoporosis, which is why so many of them get fractures and stress fractures and things like that, and energy deficiency, which can or may not be associated with the eating disorder. Now, what they found was that this wasn't a female athlete thing. This is one of the few things where women were ahead of men. And they said, no, this happens to male athletes too. Obviously, they don't lose their menstrual period. But they have this energy imbalance where they have too little calories in, too many calories out. So they've renamed the syndrome the Relative Energy Deficiency Syndrome, which stands for REDS, or the acronym is REDS, where the main problem is the imbalance of energy in versus energy out. Now, they found that not only is it associated with bone loss, but it can also be associated with decreased energy, worse performance, fatigue, decreased mental capacity, things like that. So, and a lot of electrolyte imbalances, it's a very serious disorder. So what do we want to think about when we see a patient who has hypothalamic amenorrhea? Well, we're like, we want to avoid anything that's going to decrease their estrogen even more because we don't want to increase their bone loss. Okay, so we don't want to give them the progesterone-only methods because we're not doing anything for their estrogen. Again, I'm picking on Depo-Provera, I'm sorry. We don't want to give them any of the progesterone-only methods. So what did we always do? We would always slap them on birth control pills, saying we're giving you birth control, we're giving you cycles, we're giving you estrogen. But it turns out that the best marker of recovery for women is actually the menstrual cycle. And the new guidelines from endocrine really point out that we really don't want to mask the menstrual cycle because that's the best marker we have in women to show that they're recovering from this disorder. The other thing that is really eye-opening to me is the prevention of pregnancy and the prevention of bone loss are not created equal. So birth control pills are not protecting bone loss. So even though we're giving this high level of estrogen and we're like, okay, we've got this covered, they showed that we were actually not either stabilizing or reversing any of the bone loss in these young athletes. And that the best treatment for bone loss was the estradiol patches and the oral micronized progesterone. So the bone loss protection was more from the estradiol, and they would add the oral micronized progesterone for the endometrial protection. However, what's the problem with that? We're not giving birth control, right? Because it's not high enough for birth control. So one of the things to consider, you can certainly put them on a birth control pill and monitor them. This is one of the places where you really need to have some specialists involved. You need to have the sports medicine doctors. You need to have even the coaches, the athletic directors from the schools are really helpful. But you need to pay attention to bone loss, and you may monitor it with either markers or bone density tests. Again, I defer some of this to my endocrine friends. Really pay attention to the weight, and if you're not masking the period, really pay attention to the period. So what are your options? You can do Paragard and estradiol patches, plus or minus the progesterone, because I'm not sure we know if it's the progesterone or the estrogen that's really helping. You can do a levonorgestrel IUD and add the progesterone patches in. Or like I said, the other birth control methods really aren't contraindicated except really the progesterone only ones, because you really want to watch their bone. So I thought that was kind of an interesting take. I was going to spend some time on some of the complications of LARC, like I said. I'm not going to spend too much time on that because I wanted to talk about risk-reducing salpingectomy. Data has been emerging from the prophylactic BSOs that have been done for the BRCA carriers. What they found was that 5 to 10% had a pre-existing serous tubal intraepithelial carcinoma. And it was happening in the fibriated portion of the tube. So it was in the distal fallopian tube where you were getting abnormal cells. And 5 to 10% of people with no ovarian cancer, when they were getting their BSOs, would have those pre-malignant appearing lesions. When they looked at the fallopian tubes, and this is, like I said, the really exciting part, in the non-BRCA carriers, who unfortunately already had ovarian serous carcinomas, when they went back and looked at the fallopian tubes, 50 to 60% of them had those precancerous lesions in the tube. Now again, when I was growing up in medicine, we were always taught cancer of the fallopian tube is really rare. It's ovarian cancer we have to worry about. Well, this data is pointing to that a lot of the things that we think are ovarian cancers are actually originating in the fallopian tube. And that's excellent because once you finish childbearing, you really don't need your fallopian tube. And that's what's so exciting about this. So why do they think it happens? Well, there's a couple theories on it. One is that the abnormality starts in the fallopian tube, and then during the process of ovulation, right? When you ovulate, you release of the ovary. So that's when those abnormal tubes seed into the ovary. And then the hormonal I can't say that word because I'm from New Jersey. The hormonal content and the activity of the ovary allows it to propagate, and it causes the changes that present as ovarian cancer. The other theory was that you got normal tubes, and through that same process of ovulation, the normal tubal cells got into the ovary and got transformed within the ovary. That's what they were originally thinking. It does actually explain in either case why anything that decreases ovulation is protective against ovarian cancer, right? You're not letting those bad cells in. I think right now they're saying because they're finding the abnormal cells in the tube, it's more that the abnormal cells are happening in the tube, being absorbed by the ovary, and then presenting as a primary, what we thought was a primary ovarian process. So what's the bottom line of that? There was a 2015 Danish study where they reviewed 13,000 ovarian cancer cases. They looked at the number who had the precancerous lesion that was found in the tube, and said that if they had done bilateral salpingectomies on those women, they would have had a 42% decreased incidence of ovarian cancer. And that's really incredible. Oops, I keep hitting the pointer. Bringing it home, the number to treat is 100 because of the incidence of ovarian cancer. So you remove 100 tubes, and you're going to protect one person from ovarian cancer, right? So if we do 700,000 sterilization procedures a year, instead of just blocking the tube, if we take the tube out, then we are going to reduce our ovarian cancer cases by 7,000 per year, which is about a third of the ovarian cancer cases. Now, this is only for the serous ovarian cancers, okay? But they are the vast majority, especially of the high-grade cancers that present in the ovaries. So this is really exciting, and we have started offering, it's not recommended yet, I'm going to go through the recommendations in a minute. It's not recommended yet to take the whole tube out. In our practice, we have started offering it to all of our patients who are having a laparoscopic tubal, that instead of just occluding the tube or burning the tube or whatever we do to the tube, that we're taking out the entire tube. It doesn't add a whole lot of operating time. It doesn't add a whole lot of morbidity to the procedure, and we've been doing that quite a bit. We always preface it with if we are able. If it looks like it's going to be something that is going to increase their complication rate from the surgery, if there's a lot of adhesions, we won't do it. And in our postpartum tubals, again, those are a little scarier. When you do a C-section, you have all that vascularity around the tube. It's a little bit more daunting to do a salpingectomy then. I know that some of my colleagues, I haven't done a lot of them because I'm not in labor and delivery that much anymore, but they've been using the staplers, and they've been using the staplers to do their salpingectomies during C-section, and that's a really good option as well. The other thing is, even if you just take off the fimbria, do a partial salpingectomy. Usually the fimbria are pretty free. If you take off the fimbria, you're serving both purposes. So the Society of GYN Onc and Prevention of Ovarian Cancer, again, remember, combined oral contraceptives are still protective, so we should still be recommending combined oral contraceptives to people at high risk for ovarian cancer. 40 to 50% decreased risk over a lifetime. Increases the longer you use them. Tubal ligation, just a tubal ligation has a 34% decreased risk of ovarian cancer, but that's just the endometrioid and the clear cells, because it's still believed that the endometrioid and the clear cells are more from retrograde. So they're more retrograde flow through the ovaries. So even just interrupting the tube is protecting those kinds of cancers. So if you're taking out the fimbria, you're protecting against both and giving birth control. Salpingectomy after childbearing is complete. They're projecting, because they don't have these real numbers in yet because we haven't done enough of them, they're projecting about a 30 to 50% decreased risk Again, that's in serous. So if you're decreasing the serous, the endometrioid, and the clear cell, you're doing pretty good. And then we all know that the risk-reducing bilateral salpingo-oophorectomy in high-risk women is 70 to 80% decrease. So we finally have something we can do. ACOG says that a prophylactic salpingectomy is an opportunity to prevent ovarian cancer. They recommend that we need more trials, which I think we all agree we need a little bit more evidence, although the evidence we have right now is compelling enough, I think, to make us change our practice. They also stress, and I think this is important, the approach to hysterectomy or sterilization should not be influenced by the theoretical benefit of salpingectomy. So if you're doing a hysterectomy vaginally and you have to convert it to open because you can't get the tubes, or they're saying don't alter your surgery to make it a less favorable outcome for the patient surgically because of that theoretical benefit. And that we should continue to observe and practice minimally invasive techniques as often as possible. Again, don't open a patient because you can't do a laparoscopic salpingectomy. Either take the Fimbria or just do the tubal that you were originally starting to do. Ovarian reserve after salpingectomy, that's a question people have. Well, am I going to go into menopause earlier if you take out my tube because you are interrupting some of the blood flow to the ovary, potentially? And that's kind of an interesting question. One, there's no good long-term data yet because we haven't been doing it long enough. At 3 to 4 years, the data is reassuring that it's not impacting ovarian menopause. Again, you have to look at the select population. When they look at subsequent fertility potential, again, different population, but who are the people who lose tubes, who are trying to get pregnant? People who have ectopics, people who have TOAs, where you go in and you take the tubes out, and then after that they want to be pregnant. They're showing that there's not really an impairment of fertility in those patients who subsequently want to be pregnant or go to reproductive endocrine to have ovulation stimulation. So at least acutely, doesn't seem to be any damage to your ovarian reserve. Overall, it's a low risk. There's probably a potential for earlier menopause that you may want to be mentioned. I don't think it's going to be a 10-year difference. It may be a 1-year difference or a 7-month difference. You know, that data is about to come out in the next several years. We'll find out about that, but I don't think it should change most women's decision. And that's it. Any questions? Oh, I'm supposed to do my poll questions. I'm sorry. Part of my technical difficulties of updating my lecture at the last minute and then sending the wrong, well, whatever. I don't have a poll question. So we're going to do them out loud. Which IUDs are approved for nulliferous women? The questions A, all of them. We're going to do hands again. B, Mirena, Skyla, and Paragard. C, Paragard, Skyla, and Kyrena. And D, Paragard and Loletta. Okay, so the answer is Paragard, Skyla, and Kyrena. Question 2. According to the U.S. medical eligibility criteria, combined oral contraceptives should be withheld from a healthy postpartum woman with no other risk factors for thromboembolic events for how long? I know I didn't go over a lot of these in my lecture. That's because I wanted you all to download the app so that you could answer the question. So can be started immediately, 21 days, 42 days, or 90 days? 21 days is the recommended. See, now this is what, I guess if I just X there. Okay. Question 3. Factors which may affect the efficacy of emergency contraceptive pills include all of the following except A, choosing levonorgestrel over urlopristol. This is like that New Jersey thing again. You guys don't understand it. BMI, further intercourse after emergency contraception, or all of the above. The answer is all of the above. Okay? So there are very few contraindications to emergency contraceptive, but the different pills are more or less effective, can be used for different lengths of time, and there is a little bit of an influence of BMI. And obviously, if you have sex again, you're just kind of tempting fate, aren't you? This one we've already talked about, the D&C with the molar pregnancy. The answer is we can keep the Mirena in. And then true or false, women with HIV on antiretroviral therapy should not use combined oral contraceptives due to lack of efficacy of the combined oral contraceptive. True or false? Who says true? Who says false? The answer is probably a little bit of both. There is some data, although it's not completely conclusive, but again, when it comes to birth control, not completely conclusive doesn't make us happy, that some of the antiretrovirals can interfere with the metabolism of the combined oral contraceptives and decrease their efficacy. That does not stop me from putting my HIV patients on combined oral contraceptives. Hopefully, all of our HIV patients are using condoms in addition, but I stress the fact that there may be a little bit less contraceptive benefit. So you're influencing their contraceptives, not their antiretrovirals. So it is okay to combine them with that caveat that they need to use a barrier method, which hopefully they're all using anyway. And that's it.
Okay, we have one question from the website.
It's not only
do we know the reason why OCPs do not help osteoporosis and hypothalamic amenorrhea, but the lower dose does?
no. Well, the estradiol, the transdermal estradiol does, but oral contraceptives don't. It may be it's the estradiol versus the synthetic, and that may be the answer. I don't know if it's because of the route or because of the mechanism. Do you know the answer?
Well, in the first place, if you're taking 0.65 milligrams of, for example, Primer, only about 86% of people who don't have other risk factors for osteoporosis are protected. So low-dose contraceptives don't do it for a considerably higher proportion of the population. They're approved by the FDA because 55% of the people had their bones protected. The other 45 didn't. So already estradiol is better than ethinyl estradiol for bones. And so that basically is the reason.
Question in the back?
What do you feeling on using the patches, that they're pretty strong and increased risk of DVTs?
I try not to use the patches because of that. Again, I don't know if they have a black box warning, but I think they do. I know that they certainly have higher circulating levels and they have an increased risk of DVT, but I still think that the risk of DVT on any of the birth controls is still lower than the risk of DVT in pregnancy. And so in patients where we come to a conclusion where that's the only birth control method that they want, that they will adhere to, that will be useful for them, I will do the patch. I used to love the patch. I wish they would come out with a new one that's lower dose. I don't know if that's in the works somewhere. I hope it is. But I will still use it, although begrudgingly and with good counseling.